Hi, good evening, everyone. I am Dr. Ali from Port Spain General Hospital. Tonight I'll be talking about anticoagulation and antiplatelet therapy in neurosurgery. So we're going to understand some common anticoagulants and antiplatelets, review perioperative management, and discuss emergency reversal. So neurosurgery is a specialty that carries a high bleeding risk. There's a balance to be found between preventing thromboembolisms and avoiding any bleeding, such as an intracranial hemorrhage. Even small bleeds can have catastrophic neurological outcomes. So there are two types of hemostasis. There's primary hemostasis, and this is usually done by platelet aggregation, and then there's secondary hemostasis, which is done by decoagulation cascade. This picture is just to remind us of the coagulation cascade. It depicts the intrinsic, which is in blue, pathway, the extrinsic pathway, which is in red, and the common pathway, which is in green. Now, the activated partial thromboplastin time is a reflection of the intrinsic pathway. Isolated prolongations of any PTT should prompt considerations of factors 8, 9, 11, or 12 deficiency. The prothrombin time is a reflection of the extrinsic pathway, and isolated prolongations of the PT are most often due to factor 7 deficiency. Now, for the common pathway, deficiencies in factors 5, 10, thrombin, and fibrinogen have both prolonged PTT and PT times. Now, some common agents that we see usually are heparins, which can be an unfractionated heparin, low molecular weight heparin. We have direct oral anticoagulants, otherwise known as DOACs, such as apixaban, rivaroxaban, and dabigatran. We have vitamin K antagonists like warfarin. Now, patients can be on these anticoagulants for many reasons, some being atrial fibrillation, venous thromboembolism, or mechanical heart valves. Now, with respect to heparin and warfarin in particular, for heparin, full anticoagulation in an average weighted patient of 70 kgs, we give 5,000 units bolus IV, followed with 1,000 units per hour IV drip. We want to titrate to the therapeutic anticoagulation of a PTT of around 2 to 2.5 times the control. For warfarin, which is an oral vitamin K antagonist, we want to anticoagulate the average weighted patient. We give them 10 milligrams PO Q every 2 to 4 days, and then we can give around 5 milligrams every day. Following the coagulation studies, we will titrate to the PT of 1.2 to 1.5 times the control, or INR of between 2 to 3 for most conditions. Some common antiplatelet agents are aspirin and clopidogrel, and a patient can be on this for coronary artery disease or stroke prevention or post-stenting. Now, what are some of the neurosurgical risks for a patient that are anticoagulated? They can range from having an intracranial hemorrhage, epidural hematoma, a subdural hematoma, postoperative rebleeding, or they can have thrombotic risks such as stroke, pulmonary embolism, or mechanical valve thrombosis. Now, this slide shows two criteria that is used to ascertain the risk of a venous thrombosis in a patient. The top image shows the Caprini score, which is used in surgical patients. It's a comprehensive model that assigns points for surgical risks, BMI, and other factors, and they classify the risk from 0 to greater than 8. The bottom picture shows the improved risk assessment model, which is another validated tool focusing on high-risk hospitalized patients requiring extended thromboprophylaxis. The scoring system with a low risk of 0 to 1, a moderate risk of 2 to 3, or a high risk of 4 or greater. Now, preoperative management in these patients. So generally, we want to assess all our patients. We want to assess their bleeding risks of the procedure, any thrombotic risks of stopping their therapy. So for elective patients who are on anticoagulations, for warfarin, we can stop the warfarin 5 days prior to elective surgery with a target INR of less than 1.4. So warfarin management guidelines, patients on warfarin who must be anticoagulated as long as possible. For example, patients who have mechanical heart valves in situ may be bridged to lower molecular weight heparin injections. So we can stop the warfarin at least 3 days prior to the procedure and begin administering the lower molecular weight injections. Now, patients with less critical anticoagulation needs, such as chronic defibrillation, can usually stop the warfarin at least 4 to 5 days prior to the procedure, and we will do a PT-INR when they are admitted to hospital. The patients must be advised that during the time that they are not anticoagulated, they are at risk of possible complications from the underlying conditions on which they are anticoagulated for. Now, patients who are on heparin, such as IV heparin, we can stop the drips around 4 to 6 hours prior to the planned procedure, and optionally, we can retract the PTT just prior to starting the procedure. Many dose subcu heparin, even though it's not mandatory to stop for craniotomies, if it's desired to discontinue, we can give the last dose around 12 hours or greater prior to surgery. Antiplatelets cause permanent inhibition of platelet function that persists for around 5 days after discontinuation of the drug. And this can increase the risk of bleeding. So for elective surgeries, we would like to stop it 5 to 7 days prior. So for emergency surgeries, because not all our patients will be elective cases, we have to reverse any anticoagulation that they may be on. So for example, if the patient is on warfarin, we can give fresh frozen plasma starting at around 2 units and vitamin K around 10 to 20 milligrams IV with a rate of around 1 milligram per minute as soon as possible. We can also give them prothrombin complex concentrate, right, which also is derived from fresh frozen human plasma and contains clotting factors 2, 7, 9, 10, with protein CNS to help prevent thrombosis. Now, the usual reasonable dose that we give is around 25 international units per kilogram. For dabigatran, we will use a drug called idarucimab IV for the emergencies, and that has the reversal of the dabigatran within 12 minutes with a maximum reversal time within 4 hours, and it lasts up to 24 hours. Now, for any factor 10A inhibitors, we use the drug adrexanet, and it can be given via 2 protocols. We can give a low-dose protocol, which consists of a 400 milligram bolus that is administered at a rate of 30 milligrams per minute, followed by an infusion of 4 milligrams per minute for up to 2 hours. The high-dose protocol involves an 800 milligrams bolus administered at a rate of 30 milligrams per minute, followed by an infusion of 8 milligrams per minute lasting up to 2 hours. Now, for heparin, a low molecular weight heparin, we can use protamine, which can be used to reverse heparin anticoagulation of around 1 milligram of protamine reverses around 100 units of heparin. So you want to give it slowly, not to exceed 50 milligrams in any 10-minute period. Therapy should be guided by coagulation studies. Now, reversal of low molecular weight heparins, we can also give slow IV injection of a 1% solution of protamine. Antiplatelets such as aspirin and clopidogrel, while heparin and warfarin can be reliably and measurably reversed, the situation is less clear with antiplatelet agents. Agents used pre-op to reverse these drugs include desmopressin and fresh frozen plasma. Under desmopressin, we will want to give 0.3 micrograms per kg, given over a 15 to 30-minute period prior to the surgical procedure. Now, post-op management of these patients. Neurosurgical patients are particularly prone to developing DVTs with an estimated risk of 19 to 50%, due to, at least in part, of the relative high frequency of long operating times for some of the procedures, prolonged bed rest for patients before and after surgery, alterations in coagulation status, for example, in patients with brain tumors or head injury, increased blood viscosity, use of high-dose glucocorticoids. Now, specific neurological risk factors for DVT and PE will include spinal cord injury, brain tumors, subarachnoid hemorrhages, head trauma, especially severe traumatic brain injury, stroke. Prophylaxis against DVT have many options, include general measures such as passive range of motion for the patient on the bed, the appropriate time for the patient to ambulate as soon as possible. We have mechanical techniques such as pneumatic compression boots or sequential compression devices. We have TED stockings. We have electrical stimulation of calf muscles, rotating beds, and anticoagulation, where we can give a low-dose anticoagulation of heparin, 5,000 international units sub-Q, Q8 or 12 hours, starting 2 hours pre-op. Now, the role of aspirin in DVT prophylaxis is limited because aspirin inhibits platelet aggregation, and platelets play only a minor role in DVT. Now, what are some of the anticoagulation considerations in neurosurgery? So, with respect to heparin, there have been contraindications to heparin therapy are constantly being reevaluated. So patients who have massive pulmonary embolism producing hemodynamic compromises should be treated with anticoagulation in most cases despite intracranial risks. Now, contraindications to full anticoagulation with heparin would include severe recent head injury, recent craniotomy, patients with coagulopathies, hemorrhagic infarction, bleeding ulcers, or uncontrollable hypertension. Another scenario where we find an incidental unruptured cerebral aneurysms, anticoagulation may not increase the risk of hemorrhage. However, should rupture occur, anticoagulation would most likely increase the volume of hemorrhage and thus increase morbidity and mortality. So the decision to start or continue anticoagulant depends on the indication for the drugs, such as the size of the aneurysm, where a small aneurysm of less than 4 millimeters is not too much as a worrisome. Also, patients needing antiplatelet therapy, for example, patients who are cardiac stents, should be left on their anticoagulation drugs. Now, patients who are anticoagulation or antiplatelet drugs who develop a subarachnoid hemorrhage, if they're on warfarin and antiplatelet medications, we want to reverse that. Patients with brain tumors. Now, some surgeons are reluctant to administer full-dose heparin to a patient with a brain tumor, although there have been a number of studies that have found no higher risk in these patients when treated with heparin or oral anticoagulation. Of note, the prothrombin time should be followed very closely, and is recommended at a prothrombin of around 1.25 times the control. Now, post-operatively, following any craniotomies, it requires individualization based on the reason for the craniotomy. Now, for example, surgery for parenchymal lesions, where the surgery disrupts small vessels like in a brain tumor, have a higher risk for the hemorrhage than an aneurysmal repair. Now, for full anticoagulation, most neurosurgeons don't usually fully anticoagulate patients in less than 3 to 5 days following craniotomy. Some even opt to wait until at least 2 weeks. There is a study that has been found that there's no increased incidence of bleeding when anticoagulation will resume 3 days post-craniotomy. You can use low-dose prophylactic anticoagulation with heparin about 5,000 sub-Q 2 hours prior to craniotomy and continue at Q12 hours post-op for 7 days. Or we can give enoxaparin 40 milligrams sub-Q daily. Now, for any intracranial hemorrhages who are anticoagulated, we want to do immediate reversal. And for spinal surgery, anticoagulated patients carry a very high risk of epidural hematoma, which can cause paralysis. Some key takeaways. So we need to remember that neurosurgery is a high-stake bleeding environment, right? And we need to individualize our risk assessment for each patient, depending on what they came to us for and why are they on any anticoagulation. We need to carefully time any discontinuation and resumption of their patient's anticoagulation. And you must remember in emergency settings, any anticoagulated patients, once it's indicated, we need to do rapid reversal. These are my references. Thank you for your attention.